Good morning. It's my pleasure to be able to speak with you today, and I want to thank the organizers for inviting me to speak at your meeting. I do apologize that I'm not able to attend in person, but look forward to maybe virtually seeing you during the question and answer session following my presentation. Today, I'd like to give you some of my perspectives on climate change as an emerging pediatric respiratory health, social, economic, and public health issue. I do not need to tell this audience that climate change is putting our planet and all its inhabitants at risk. We're here today because we're concerned about the impacts of climate change on health, and in particular, the health of our children and their respiratory health. As you're aware, national and international organizations have coalesced and issued proclamations of concern. A recent Intergovernmental Panel on Climate Change report was called a Code Red for Humanity by the UN Secretary General. There is irrefutable evidence that greenhouse gas emissions from fossil fuel burning and deforestation are choking our planet and putting billions of people at immediate risk. Global heating is affecting every region on Earth, with many of the changes becoming irreversible. And that's very exquisitely represented on this slide, where we're just looking at a few examples of the effects of global climate events in 2022. One of the reasons I put this slide up here is that I want to make the point that those that are most at risk will be the under-resourced and marginalized populations. In addition to urgent calls for climate action to mitigate and adapt to climate change from the policy community, there have been many recent calls for climate and health research to protect health around the world. Scientific journals, academia, and nonprofit organizations are among the leaders asking for research to harness the health benefits of climate action and identify gaps in the research that can be utilized to reduce mortality and morbidity. The world needs a new era of research that can help guide both health authorities and the many socioeconomic entities that affect our well-being in a changing world. No matter how well we fare at reducing the emissions of greenhouse gases, the world will continue to warm with enormous consequences for health, especially for the most vulnerable among us. I'd like to point out that on this collage is an article that was published in November of 2022 from 7 of the NIH Institute and Center directors discussing a new climate change and health initiative and strategic framework and how we as an NIH agency are addressing the threat of climate change to health and our call to action. The overall goal of this initiative is to reduce health threats across the lifespan and build health resilience in individuals, communities, and nations around the world, especially among those at highest risk. As we know that climate change will impact all of us, it will also affect almost any health outcome that one can consider. And therefore, it makes sense that the NIH as an organization has coalesced to develop this initiative. The objectives that are defined are to identify risks and optimize benefits, develop the necessary research infrastructure, leverage partnerships, and innovate across the translation continuum. The centerpiece for this initiative is illustrated on the right side of this slide, and it includes what we call the 4 core elements. These are health effects research, health equity, which will be emphasized and integrated throughout the initiative, requiring the elevation of the concerns and rights and focused attention to the lived experience of the most affected individuals and communities to ensure that the benefits of scientific discovery create greater health equity. Intervention research that can guide both individual actions and policies at the community and population levels to improve health outcomes now and in the future. And of course, training and capacity building. The outside cogs represent areas of science to inform the 4 central elements, and the blue ribbon depicts the critical role for partnerships at the global, cross-sector, interagency, and community levels to bring all knowledge together to create transdisciplinary, transformative research that will be necessary to address the challenges climate change pose to health. And one point I'd like to underscore in this initiative that is really a very solution-oriented program in taking that knowledge and moving it to action. But we must also be cognizant that though climate change may affect all of us, there are many that will be disproportionately affected. And for the purposes of today's conversation, this includes underserved populations with health disparities. For example, some communities of color, low-income populations, low educational attainment groups, immigrant groups, and indigenous populations, as well as vulnerability of life stage, young children, infants, pregnant women, the elderly, consideration of climate change impacts on the pregnant mom and on fetal and prenatal development, because we are aware that effects neonatally or prenatally can impact health of the individual throughout their lifetime. And just so that we're all on sort of the same page, I just wanted to put this slide up here to just articulate the impacts of climate change on health and what we're talking about here. Some of the changes that we are seeing include increased global temperature, extreme weather and disasters, precipitation extremes, sea level rise, and changes in land use and growing seasons. These changes can cause direct and indirect effects such as extreme heat, air and water pollution, reduced food and water quality, changes in infectious diseases, and vector transmission, as well as increases in allergens. These effects can in turn influence our health, causing health-related illnesses, cardiovascular disease, stroke, and other chronic conditions. And of course, what we're talking about today, respiratory diseases and asthma. So if we drill down a little bit further and focus on children, we are aware that climate can affect children's health. We know that there's heat associated with higher rates of preterm birth, low birth weight, neonatal distress, and also are cognizant that preterm birth and low birth weight can have long-term impacts on children's development and future health outcomes. Heat and precipitation increase transmission of infectious disease in children. Drought leads to child malnutrition, which is associated with reduced educational achievement and mental health. Children are more vulnerable to PTSD after extreme events. Flooding increases diarrheal diseases in children. Exposure to particulate matter is associated with behavioral problems in children, and air pollution in early onset spring can exacerbate allergy and asthma in children. It's been estimated that climate change under high emission scenarios could cause an additional 48,000 deaths in children under 15 years in 2030. And so I just want to even drill down a little bit more into the climate change impacts on asthma. If we look at the climate air pollution nexus, which I think is a significant driver for respiratory health, we see that that climate change can impact air pollution, air allergens and pollen, extremes of heat and cold, floods and natural disasters. These more intense rainfalls and flooding can lead to mold growth in homes, which could lead to asthma and stress. Heat and drought increase in wildfire leads to spikes in particle pollution, which can increase asthma, COPD, and infections. The heat extremes can increase respiratory morbidity and mortality. And longer warm seasons result in longer pollen seasons, which increase air allergens, pollens, and molds that can again have an impact on increasing incidence of asthma and rhinitis. If we consider climate change as an emerging pediatric respiratory health, social, economic, and public health issue, I think we need to consider this we need to think about these issues holistically to understand the cumulative effects of exposure disparities, social vulnerabilities, and biological susceptibility, and how they interact to influence health outcomes and disparities across the lifespan. Thinking about what we mean by environmental disparities, we at NIHS think about the totality of exposure to include not only sort of physical and chemical exposures such as air pollution, fragrance products, food contamination, soil contamination, et cetera, but we also think about lifestyle exposure, physical activity, diet, the environmental disparities in ecosystems, built environment, land use patterns, population density, walkability. Another element of this totality of exposure disparities is some of the, we can also consider social vulnerabilities, household income, social capital, social networks, et cetera, as part of that totality of environmental disparities. So the second piece we also need to consider is thinking about the effects of social determinants of health, which is that second pillar, which is defined by the social circumstances in which people are born, grow, live, work, and play. Social determinants of health are shaped by the distribution of money, power, and resources at the local, national, and even global levels. Research, as we all know, has revealed that the changing climate is inextricably linked to poor health, and that the social determinants of health will profoundly affect children's health and drive health disparities. But I'd also like to posit for the pediatric healthcare community that we should be called upon to view the changing climate as another critical social determinant of health that both increases cost of care and negatively impacts child health both locally and globally. Viewing climate change as a social determinant of health could potentially help coalesce a large group of ideologically different stakeholders around the common goals of decreasing healthcare costs and improving child health. Projected costs of climate change to the healthcare system are staggering. For example, health costs, including premature deaths, hospitalizations, emergency department visits, and outpatient appointments of 6 climate-related events from 2000 to 2009 was estimated to cost $14 billion. But as we consider that interaction of the biological, social disparities, and environmental disparities, I think there's another factor that we need to consider that really underlies all of that, and that is thinking of structural racism in health and structural racism as we think of chemical exposures of toxins, that we should also start thinking about structural racism as a toxin as well. Racialized social structures determine differential access to opportunities, risks, and resources that drive health. Discrimination has been linked to adverse mental and physical health outcomes. Segregated areas which lack quality schools, good jobs, safe housing are a driver for racial health disparities. The physical and social conditions that characterize segregated areas lead to elevated exposures to chemical hazards and psychosocial stressors. When we think about structural racism, we must also consider how our social policies shape people's exposure to risks and their ability to access resources that allow them to make healthy decisions. Now, if we go back to the 1930s, the federal government created maps of hundreds of cities, rating the riskiness of different neighborhoods for real estate investment by grading them best, still desirable, declining, or hazardous. Race played a defining role in that Black and immigrant neighborhoods were typically rated hazardous and outlined in red, if you look at the map at the top, denoting a perilous place to lend money. By contrast, white neighborhoods were often outlined in blue and green and were subsequently favored for investment. This historic policy, called redlining, has lasting effects that continue to influence disparities in health exposures and access to health promoting resources. Compared to best rated census tracts, redline tracts have higher percentage of Black and Hispanic, non-Hispanic Black populations, greater diesel emissions, increased poverty rate, and much higher rates of asthma-related ER visits, as you can see on the right side of this slide. These effects of redlining aren't localized to specific neighborhoods or regions, as was discussed on this slide, that was focused on San Diego in publications by Nardone et al. In 2020. But this group also looked at how redlining has been felt nationwide. This has been evidenced by their study, which looked at 102 urban neighborhoods across the United States and found those that were assigned worse investment risk grades in the 30s, as I mentioned, redlining, have less green space today and are also at greater risk for impacts from climate-related events. We've already talked a little bit about environmental determinants of asthma, and it's important to address health disparities in different populations. I'm just putting this slide up to again bring the point across that the prevalence of asthma is disparate across different racial groups. Black and Puerto Ricans have a much higher rate of asthma prevalence compared to whites. This is even greater in children as compared to adults. We also know that place matters, that children in communities of color will have higher exposures to air pollution, and there's a lot of implications for lung health. On the left slide here, on the left part of the slide, in a study by McCarty et al., they were showing that there's disparate exposure to air pollution across U.S. communities, where Black and Hispanic communities have a much higher burden and disproportionate burden of air pollution. And many times, not only disproportionate burden of air pollution, but many other types of exposures. In the study on the right by Gotterman et al. In 2004, it showed that in Southern California, more pollution correlated with reduced lung function. And this is from 2004 data. They show that there was nearly a 5-fold difference between locations with the lowest and highest particulate levels. In Southern California, more pollution correlated with reduced lung function. Pollution-related deficits in the average growth in lung function over an 8-year period resulted in clinically important deficits in attained lung function at the age of 18. Across the 12 communities that were studied, there was shown a clinically low FEV1 being positively correlated with the levels of exposure to PM 2.5. Although the research surrounding climate change has grown in the past few years, research documenting health disparities has also grown over the last many years. There are still many needs for evidence-based research that will propel climate change mitigation and adaptation actions forward, and in the considerativeness of health disparate populations. This includes needs for advanced scientific discoveries, need for transdisciplinary understanding of the complex causes of changes in health today, with the many concurrent environmental stressors, social vulnerabilities, biological susceptibilities, as well as structural racism factors that are connected to those changes. There's a need for assessments of the tipping points, that is the critical threshold that, when crossed, leads to large and often irreversible changes in the climate system that will pose risk to health to take preventive actions. And also a need for evidence-based research that will enable tangible actions. For example, some of the could be focused on facilitating early warning systems that warn of impending climate changes on human health. evaluating not only the beneficial but also adverse effects that climate change mitigation and adaptation effects have on human health. There are mostly benefits to health stemming from these efforts, but sometimes there are trade-offs to health, and we need to understand those. Gathering of data that will give the health and climate change community a reliable overview of the level of progress towards meeting national and internationally agreed targets will also be important. And we need to make sure that the use of data is done to enhance both accountability and transparency. So we need to move from documenting health disparities to actions. One way of doing this is considering different intervention and implementation science approaches for exposure reduction, mitigation, and remediation. Think about approaches, interventions, implementation science to access health promoting resources, services, and spaces. EJ communities need improved access of preventive health care, environmental monitoring, mental health services due to the susceptibilities developed due to the legacy of disproportionate exposures to chemicals in their environment. Climate justice, prepare for climate change and weather disasters that will affect decayed infrastructure. Green space, trees, parks for temperature and physical activity. Clean, safe housing in neighborhoods. Trash pickup to reduce pest odors, traffic control routes, reduce air pollution for outside walkability, access to food and exercise, urban gardens, investments in supermarkets, healthy choices, food co-ops. These are all things that we need to think about and consider as we create a holistic approach for documenting those health disparities, but moving to action to provide health equity to all. I just wanted to provide a couple of slides on some benefits that we've seen from taking different kinds of intervention implementation strategies. The first study that I'd like to just mention briefly is on this slide. Like many urban areas around the world, New York City experienced a sharp decline in air pollution during the COVID-19 shutdown, led by Dr. Federico Pereira and research from the Columbia Center for Children's Environmental Health. They took this unique opportunity to simulate a scenario in which the citywide air quality improvements during the shutdown, if were sustained over 5 years, to see what would happen if sustained over a 5-year period. This allowed the researchers to estimate the potential public health benefits to children and adults and their associated economic benefits. The research team focused on PM 2.5 and modeled potential future health benefits. The analysis considered outcomes in children that have not generally been accounted for in clean air benefits assessments, including preterm birth, term low birth weight, infant mortality, child asthma incidence, child asthma hospital admissions and emergency department visits, as well as adult mortality. They estimated a citywide 23% improvement in PM 2.5 levels during the COVID-19 shutdown months compared to the average level for those months in 2015 through 2018, the quote, business as usual period. Based on the data for 2020, they extrapolated the ambient levels of PM 2.5 for the following 5-year period. They estimated cumulative benefits for 2021 through 2025 included thousands of avoided cases of illness and death, with associated economic benefits from anywhere from $31.8 to $77 billion. This natural experiment, tragic though the cause, has provided a hypothetical clean air scenario that can be considered aspirational, one that could be achieved through transportation, climate, environmental policy that support robust economic recovery with similarly reduced emissions, and which would also be impactful on meeting climate levels. Another example that I'd also like to point to is another study that was funded by the New York Health Department neighborhood health action centers were launched in 2016 and 2017. And these were launched to address health inequities at the neighborhood level. The centers used a place-based approach to improve health in neighborhoods with disproportionate burdens of premature mortality by co-locating clinical and community-based services, leveraging referral systems to facilitate linkages across service providers and to meet residents' social and health needs, engaging communities and bringing in the lived experiences and input of marginalized groups to inform programs and services offered. They hosted pop-up services, legal services, mobile dental health clinics, for example, and they also offered a vibrant community space and local programming. The city funded these action centers in Bronx, Brooklyn, and Harlem. In its first year, the East Harlem Action Center received more than 15,000 visitors and made 600 referrals for health and social needs. So this is something doable. You know, I think as we're thinking about action and how we break down some of the health inequities that we're seeing, some common sense approaches that are described here, I think could be very valuable as we think about solutions to improve the health of the nation and of communities that are disproportionately affected. And so I'd like to posit that as air pollution interventions can be considered in clinical medicine, that environmental air pollutant biomarkers are readily available through geospatial data and can be used to inform therapeutic strategy for clinicians to better address a patient's environment at the bedside. And so, you know, thinking about how we can take the knowledge that we have in defining some future clinical strategies, we consider greater training of healthcare professionals in environmental health sciences. Think about including exposure histories as part of electronic medical records, being aware of the impacts of natural built and social environments. Think about capacity building and attention to behavioral health specifically related to trauma, and assess health and human service needs for minority and low-income populations in Indian tribes. You know, some of the examples are presented on the previous slide, which could also include improve access to health services. And so this slide sort of reiterates that point, in that population higher risk of exposure to climate-related health threats, that shows not only what the risks are, but some potential strategies to mitigate those. So for example, in children, you know, having adults can help lessen the risk by monitoring exertion and hydration. And so to expand a little bit more on clinical settings, patients can, we can educate our patients and parents on disaster preparedness and provide resources to families and parents of children who are impacted by climate change. Pediatricians can discuss climate change in clinical settings by including to educate about disaster preparedness, provide resources to those impacted by climate change effects, educate on actions that families can take, provide developmentally appropriate materials to support parent-child discussions, connect the impact of climate change has on other social determinants of health to address a range of unmet social needs. There are many challenges that we're also going to need to face. A couple of them listed here is that they're not always community-based resources or clinics to offer patient referrals to, like with other social determinants of health. And some components of, and often when social is discussed between a patient and a provider, actions, measures, and change that they can take is a difficult conversation. However, you know, some of these components, you know, can't just rest on the patient and it can't rest on the provider, but many of the components for addressing climate change may best be accomplished by a policy level, such as reducing carbon emissions. So want to wrap up and in summary just say that, it's important that we address climate change on health and promote health equity. There is a role for all of us in doing this by using community engaged alliance to empower community-driven sustainable strategies to address climate change. By you, I think, as clinicians and providers, are a trusted source of information in the community. Establishing those partnerships, being a point to be able to address misinformation. You're seen as you can increase trust in science and therefore help accelerate the uptake of beneficial interventions. So at the end of the day, it's going to take all of this. It will require those multi-sectoral partnerships that I've been talking about. There's a clear role for the research community, academicians, for communities, for health professionals, and all working together. I believe that we can make a difference. And with that, I want to thank you very much for your attention. And here are some resources on the NIH side that you might want to consider looking at. And thank you again for your attention.